is the superior lateral brachiocutaneous nerve, which is the one that pierces through the fascia just posterior or inferior to the posterior deltoid.
And what nerve trajectories, Dr. Timmermans, that we have to be mindful for? I know we're dealing with the.
On the anterior shoulder, not much.
Not much. Okay.
No, because your brachial plexus is going to be super deep and midline to the humerus, and so we're not really getting into that area. The brachial plexus up here is going to run underneath the clavicle, and so not a huge concern. If you start going into where you're now medial to coracoid process or anything like that, that's where it'd be a bit more concerning.
Okay. And this axillary nerve, it comes out underneath the deltoid and wraps around?
Sorry, say that again.
Axillary nerve? I know that comes out at quadrangular space.
Yep.
And then it wraps around underneath the deltoid?
Yeah, it wraps around the humerus.
Around the humerus, yeah, so very deep.
Yeah, very deep. But then the cutaneous branch that it gives off is the superior lateral brachiocutaneous nerve, which is the one that pierces through the fascia just posterior or inferior to the posterior deltoid. All right, so remember, how do we start to identify our structures with the ultrasound? What's the first thing you want to look for?
Bony landmarks.
Bony landmarks, okay? So what you're going to be looking for is a sharp hyperechoic line with anechoic underneath, okay? This here is a really great example of an artifact. So imaging is never perfect. There are things that can create artifacts, which are basically they're fake, okay? They're not actually present. So this here is a type of reverberation artifact where basically what's happening is because this is very perpendicular to the sound beam and in the midline, what's happening is you're seeing a shadow or a reflection that is deep to a hard structure that is an artifact. There's no bony irregularity here, and the sound's not actually getting deeper than this. It's just an artifact of the image, okay? So we have bony structure here, and then we can look at several different layers, and you can start to kind of piece together what might be going on in this area, okay? This up here is the classic look of muscle. And we know that the first layer, when I'm here, the first layer that we have to go through is going to be what muscle? Deltoid. So we know that this is deltoid, okay? Then we start going deep. And at this location, we know that, okay, it's got to be deltoid, and then what underneath?
Infra,
or maybe biceps is going to be way more over here.
Maybe supra.
Either infra, supra, or kind of a combination of both of those because of the plane that we're looking at it in. Okay. So I generally start my scan over biceps tendon. Okay. If I go to the anterior aspect, you see how I can't really see a groove very well over the humerus. Go supinated for me.
Yeah.
Let me flip this.
Is that right?
Oh yeah.
Okay.
There's our biceps tendon, okay? Remember, our biceps tendon has what I like to call a coin-like appearance, right? It's really shiny. And then we can follow that there inferiorly more into the groove. And you can actually see by my palpation, I was too medial on my palpation. And what I was likely then palpating...
Well, you had me out here when you palpated it.
Yeah, still too medial. And that would be a function of basically a fibrous, like a tighter fibrous band in his anterior deltoid that misled us all for his biceps tendon.
Could that be the coracobrachialis?
No, because over that spot, it's all just deltoid. So, there is our biceps. Biceps tendon here, which you can then follow that in its groove superiorly, and then that can continue upwards, and actually, as it continues to dive into the joint. So that's actually an intra-articular portion of biceps.
So it's just a fan out, right, as it's getting closer to the labrum.
It does a little bit, yeah. You can then continue that down. You can still see the biceps tendon there. Coin-like appearance. We continue to travel that down. And then you see, so watch right here, and then it'll move down this way. See the black line starting? That's the muscle. So that's the myotendinous junction. And then there we see biceps really starting to take full effect. Around the place where we have that myotendinous junction of biceps is you start to see pec major, right? So top pec major, excuse me, pec major, coming over, coming over, coming over. And you can see it. What is the other spot there? Tendon. So here's the tendinous insertion of pec major. So if you're ever going to treat an insertional pec tear, that's where you'd be treating it. You can see that traveling over. And this is a great example of, remember how we talked about, I think it was last week or 2 weeks ago, how the tendon forms inside the muscle first. It's not like it just goes muscle, 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 and then boom, tendon. Mm-hmm. So here's the intratendinate or intramuscular portion of the tendon that's forming that then continues to become tendinous before its insertion. Okay. So we got our bicipital tendon. Okay. We can also then flip it and we can look at it in long axis. So remember, this is short axis for the tendon. This is long axis for the tendon. So there we can see the length of the tendon, and again, you can continue to travel that up. Continuing, continuing, and you can see it then diving into the shoulder joint. So then from here, we can obviously go medial, and then we see that bony portion there is the what?
The groove? The bicipital groove?
So this is the groove, right? Because that's where the tendon is. If I go just medial to the groove, what bony landmark do we have?
Subscap attachment?
Which is?
The last one.
Yeah. Okay. We go back to the groove, and we go just lateral. What do we have here? Greater. Okay. And so we can look and we can appreciate some cortical irregularities on the greater tubercle here. See those? How we're kind of losing the sharpness on the bone there, right in this region here. And we didn't really see that all that much on lesser. Lesser actually looks pretty good. Okay. So there are, when you start really getting into ultrasound, there are specific positions that you have patients in, specific planes that you're looking at muscles for evaluating, which is obviously really great to learn, but it's also important for you to be able to have the anatomical knowledge to just know that, okay, I'm here with biceps, and when I go lateral, I know that that has to be the insertion of supra and infra onto the greater tubercle of the humerus, and without it being in the exact plane that your the book might tell you to look. Okay. So let's come here to supra. So easiest way to find supra is first to palpate for where you have that V, because you know that the supra has to run underneath the acromion, okay? A little bit more depth. So, we have the top muscle here, which is going to be what? Trap. And then deep to that, we are going to have
Supra.
supra at this position, right? If we were below the spine of the scapula, then we'd have trap and then infra. So we continue. Here is the acromion, okay? So we want to be going past the acromion, and then what comes out on the other side is our beautiful bird's beak view. Okay. This is our greater tubercle, and this is our insertion here of supra. So that means all of this is supraspinatus. What do you think this right here is? This black spot?
Is that bursa?
Nope.
Cartilage.
Nope.
Artifact.
Yes.
Anisotropy.
Anisotropy. Well done, Alan.
You taught us well.
So remember that if we are not perpendicular to what we are looking at, we can not see something because the sound waves are not hitting. And so what happens is when I apply toe pressure, I can bring that back into view. So we can actually see it now because I've just changed the angle at which we're looking at it. See how it's dark? And then see how it lights back up.
It's an awesome separation of fibers here.
Yeah.
You
Yeah.
can see the fluid in between.
So
Thanks for really going for that.
this here is the bursal fluid. This here is the inferior portion of the bursa. This is the superior portion of the bursa with bursal fluid in between. This is a normal physiological amount of fluid. I wouldn't consider that pathological, but this is actually more than generally what you'll see, but it still falls within the range of normal. Okay. You also know that it's not a tear, because if we follow that line, do you see how it continues past our insertion of supra? See how it's continuing past? That's how you know it's the bursa. It's continuing past the insertion. If it was a tear, it would come down and it would insert onto the greater tubercle. Okay?
Our long axis, like that would be a long axis tear versus a short axis tear?
Well, so long axis and short, you would want to say longitudinal or horizontal if you're referring to tears.
Okay.
We don't use a long axis and a
Yeah.
short axis really.
That makes sense.
That's more for imaging purposes.
Mm-hmm.
Okay? Can I get a bit more chill? Thanks. So there again is our insertion of supra and long axis. So if you want to, this is a really good way to learn what things look like in different planes, because it's super easy to find long axis. It is much more difficult to find short axis. I lost it there. All right, so here, and then we're going to rotate. So that there in the middle of the screen is your short axis of supraspinatus. See how that is a lot more difficult to see and make out what it is? And then you continue that down, and there's its distal insertion. And you travel it back up, and then you can see muscle, the tendon. Okay? So that's why it's good to learn specific positions for that and then rotate to see what it looks like in different planes. So there's our supra. Now to find infra, you can take the same approach and just start inferior to the spine of the scapula. So again, you could come and actually find the spine of the scapula, which is in the middle of the screen there. See the little peak at the top? So then we know that inferior to that, we're going to have infraspinatus. And then here's infraspinatus starting the tendon. And then its insertion. So, pretty close with our palpation. We lost it, but pretty close on our palpation for infra. So if you end up coming to the shoulder and you look at something and you go, I don't know if that's supra or infra, follow it back. If you see the acromion and you see it diving underneath the acromion, you know it has to be supraspinatus, right? Because from here, see how that looks really, really similar?
Super similar.
That's infra. That's supra.
So go back to infra. Follow back. What's that black line there?
Here,
Yeah, is that just ancestral?
that's muscle.
Okay.
Below that.
Right there.
Oh, below it here, you mean?
Yeah, the kind of splitting between.
Like right there.
In this way?
Yeah.
Mm-hmm.
Oh, that's muscle tissue
Okay.
Yeah. of infra. Bring your arm across your body and hold there. So again, this is our, which one do you think this is?
Infra.
Infra, right? Because we don't see it going underneath the acromion. When you travel infra back, that's where you can find your axis, find access to the posterior shoulder joint, okay? So right here, that is the posterior glenoid rim. Here's the head of the humerus. Head of the humerus with the anechoic cartilage over top. Here's labrum extending out to capsule. There's a good picture there too.
So you'll see this blow up with fluid.
You actually won't see it blow up with fluid
'Cause
if
it
you're inside the
disperses.
joint. It will flow down and it won't balloon out, and that's one of the ways you know it's in the joint.
Even with hydrodilation.
With hydrodilation, you will see some ballooning out towards the end of it, but it will follow the contour of this. Whereas if you're outside the joint, it will balloon up like this, and it won't follow the contour of the joint. Whereas when you're in it, it will follow that
Got it.
contour.
Right.
Very good. So, glenoid rim, humerus, labrum here, and then capsule. So when you're doing this injection, you can either come from this way or this way, but the goal is you want to get, you basically want to get right about here. So you want to lay on top of the cartilage but deep to the labrum. Okay? Alright, we got a few minutes here. Relax the arm back down. Let's look at your AC joint. AC joint is super, super easy to see.
There it is. Just a gap.
So here's short axis of clavicle. See bone, see bone, see bone, see bones. Bone. See that drop off? That is the joint space, which in short axis, all you can really see is just this round void here. That's the joint capsule and the joint space, right? Because there's clavicle, joint space, acromion. Joint space, clavicle. So then we can turn and we can see clavicle, joint. Here's some of the capsule, it's a little swollen, and then acromion. Oh. So in your injection, you can do an out of plane approach like this, or you could flip it this way, find it there, and you can do an in plane approach. Either one will work. That's actually a good picture. There you can see the large joint space. Okay? That's kind of the bulk of the shoulder, the basic stuff. Any
Are we
questions?
able to see Terry's or no?
Oh, yeah. So let's start with so there's infra. And there's Terry's.
That looks just like infra.
Yeah. But it's more inferior.
Right.
So there's Terry's. There's infra.
Okay.
But you see how like that muscle just like looks all, and it's actually there's the transition where you kind of see that shininess going across it.
Mm-hmm.
That's the fascial plane, and then you're into Terry's.
Very
Yeah.
similar.
Yeah.
In insertion origin.
Terry's. Infra. Supra.
Terry's is a little bit more of the abduction.
Say that again. Say that again.
Because infra, they both do external rotation, but Terry's is a little bit more of the.
Yeah, because it sits lower down, so the leverage point is a little bit better.
Right.
Yeah.